Hey all, this is Anthony Pollard Ginsberg doing my presentation on pneumonia. Signs that one may have pneumonia are diarrhea, rash. If the rash is present, it really varies greatly by the actual causative agent as well as the cytotoxins that are creating that rash. Pharyngitis or just inflammation of the back of the throat and tonsils. Mental confusion, if it is severe enough, blood-tinged sputum, tachycardia is usually the most prominent in the beginning, but bradycardia can be present once it becomes a very severe infection. Low oxygen saturation is one of the most predominant. Wheezes and crackles can be heard upon inspiration, and fever is also notable. Symptoms include difficulty of thinking or processing information for the individual, predominant headaches, ear pain, abdominal pain, and difficulty breathing. There's so many things that can cause pneumonia. The two most common are Streptococcus pneumoniae and Staphylococcus aureus. Streptococcus pneumoniae is just usually known as pneumococcal infection. Staphylococcus aureus is usually just referred to as staph. If it is methicillin resistant, then it becomes MRSA. Enterococcus is another one that's found all the time. However, these can range to viral infections as well as in some cases, in very rare circumstances, they can be fungal as well. Just about anything can get into your lungs. S. pneumoniae has two primary mechanisms to increase its virulence of infection. Number one is the polysaccharide capsule has some tricks. Number one, that capsule prevents phagocytosis in the lungs, which just simply allows the organism to survive longer and start spreading a little bit faster than it could if that were checked by the neutrophils. The other one is surface proteins, or I should say neutrophils and macrophages. The surface proteins also help prevent activation of complement, which does the bacteria some wonders in being able to spread as well, and preventing that whole cascade from being triggered. The pili that are located on the outside of the membrane are also perfect matches after thousands and thousands of years of evolution for attaching to the epithelial cells in the upper respiratory tract. The pathophysiology, this is my favorite part. Because as someone coming into it from this side of things, that's the thing that's most interesting to me. So despite the fact, like I stated, that there are a number of microbial agents that can cause this, I'm predominantly going to stick with Streptococcus pneumoniae, which according to Porth and Van Meter is both the most common and the deadliest strain of this infection. And I think the CDC also agreed with that later on in this presentation. According to Van Meter and Hubbard, Streptococcus pneumoniae is problematic because it's actually cytotoxic to the epithelial and endothelial cells that line the inside of the lungs. This directly reduces any inflammatory and immune response and results in the bacteria staying in the lungs without much contest from the body. The small hair-like appendages known as pili extend from the cellular membrane and affix themselves to the epithelial lining of the lungs. This helps anchor the bacteria in place. Once it is anchored into place, it starts producing these toxins and it grows and multiplies, which then reacts with the epithelial lining of the lungs. During the infection, the lung tissue responds with acute inflammation of itself, which calls neutrophils to the site of the infection. According to Zarbach and Lay, these neutrophils are circulating within the blood and then begin to marginalize in the bloodstream to the outside of the capillary walls. They then begin to slow down and exit through the gaps in the endothelial lining and lumens of the capillaries. Once outside the bloodstream, they mount an attack against invading bacteria. They do so by releasing oxygen-reactive compounds, antimicrobial proteins, as well as enzymes that attempt to degrade invading microbes and then phagocytize them. It should be noted that in the case of streptococcal pneumonia, the capsule itself helps prevent the body from being able to do so. And the bacteria also has those surface proteins that slow the body's ability to activate complement as well. The neutrophils then begin to release what are called neutrophilic extracellular traps, or nets, which is an appropriate name because it's actually a chromatin mesh that's laced with antimicrobial proteins that trap and neutralize these invading microbes. This process is important because the lung itself reacts to this inflammation process by reducing their own exudate, and which causes fluid to build up in the alveolar sacs, which result in a solid mass, as well as blocking the small bronchioli. Um, this is a major issue because you've got nets, you've got neutrophils, you have everything being produced, you've got the bacteria itself. Now we have exudate from the lungs. Those alveoli and those small bronchioli block up pretty quickly, and this is what causes the reduction in gas exchange in the lungs, which is usually the most predominant complaint of a pneumonia infection. Epidemiologically, 900,000 Americans come into contact with pneumococcal pneumonia annually, so the incidence is very high. 400,000 hospitalizations annually in the United States. 90% of all of these cases are in adults. 3,700 deaths occur annually in the United States, mostly among the immunosuppressed or the elderly. This is a end-stage terminal disease, meaning this generally is what ends someone's life when they're suffering from other diseases, whether that's HIV or whether that is a burn victim that has a lot of smoke inhalation and is catching many, many, many diseases as it goes along here, or as they progress. This is generally what ends someone's life in a situation where they are immunocompromised. Pneumococcal pneumonia is also responsible for approximately 75% of all pneumonia cases, which is pretty high. Diagnosis. The primary diagnostic test for this particular strain is going to be a sputum gram stain culture. Generally, we run a culture and sensitivity at the same time, as well as a chest x-ray. This is generally done first. Once we actually see that there is diffuse liquid in the lungs, then we start to look at sputum cultures and things like that in order to confirm what is the actual issue in the lungs. Supporting tests can include CBCs, blood cultures, lactic acid levels, a lot of different things to try and rule out the fact that this has entered the bloodstream, because that can present a whole host of other issues if it does cross the bloodstream. With the sputum culture and gram stain, the patient is asked to cough up mucus from the lungs. Oftentimes they're only able to produce spit. That doesn't do us any good. If we just get spit from the person, we don't need to know what bacteria are in their mouth. We are really interested in what is coming up out of the lungs. So we can obviously use a bronchoscopy in order to ascertain that culture. We then take the sputum, we allow it to dry. A gram stain is applied to the sputum. The gram stain binds to the peptoglycan wall if there is one present. The other thing that this is really helpful for is not just saying, like, yes, this is a gram-positive bacteria, and yes, a bacteria exists in the lungs, but it also means that it's easier to visualize under a microscope if it does gram stain, so that we can actually help visualize it. Another thing, too, is this test can be particularly helpful in seeing if the microbe is negative. We can still use that stain in order to help contrast that image under the microscope. But it's also helpful if seeing if fungus is present as well. Typically, as I mentioned earlier, we also run a sensitivity on the same culture to make sure that the antibiotics that we're going to be giving that patient are effective down the line, and that they're not coming back to us a week later with a much worse infection in their lungs. Treatments, since there's such a huge host of microbes, treatments really vary. However, in the case of Streptococcus pneumoniae, levofloxacin and azithromycin seem to be two of the most common antibiotics used for treatment. Bronchodilators such as albuterol are often given to assist with breathing and open the airways. Some non-pharmaceutical responses, we have to use a lot of different treatments when someone is dealing with this. Oxygen's oftentimes used just to assist with breathing and get those oxygen saturations up. CPAP is also heavily relied on in severe cases, and in very severe cases where sepsis is also present, I've seen it go all the way to intubation. Fluids, IV or oral, just to help with the hydration during infection in order to help the person fight infection and stay healthy during that process. as well as back percussion and or suction. Prevention. Pneumonia vaccine should be considered by all elderly adults. I think it was Porth that mentioned that it's about 70% as effective in elderly adults as it is the normal population. However, because the severity of infection is so ridiculously high within this population, 70% is great. That's a huge help. It's better than nothing. So, despite the fact that it is a little bit less effective in this population than others, we really heavily rely upon it. Stopping smoking. That the smoke does a lot of damage to the inside of the lungs, both in terms of its ability to mount a defense, as well as destroying some of the cilia and hairs and things like that that are in there that protect the person from absorbing these kinds of microbes. Aspiration precautions taken in populations with those that have a high likelihood of aspiration. That's a lot of folks. That could be stroke, that could be kids with feeding issues, this could be individuals with seizure disorders. The other one is people who take a lot of inhaled steroids in at-risk populations. It's hard to tell someone not to use it as often, but not over-prescribing it when it might not necessarily be totally needed is a way of keeping the immune response a little bit higher in those sets of lungs. Using contact precautions with those who are in the hospital helps reduce hospital-acquired infection of pneumonia, especially around those who are immunocompromised, and keeping those people in correct rooms. Another one that I think was mentioned by Van Meter and Hubbard that isn't on here, that's at least not a bullet point, is individuals who have inhaled serious chemicals, prophylactic treatment, assuming that they are going to get pneumonia and assuming that they are going to get an infection in their lungs from the fact that their lungs are so immunocompromised is also very important. And these are my references. Thank you very much. I've appreciated the class and I've appreciated the opportunity of being here. I certainly understand why every other nursing school on the planet requires this course before you are allowed to attend nursing school, but I'm glad that I did it even if it was after the case.